Hi, welcome to BariNation, where we support the bariatric community with humor, humility, and honesty.
You've just tuned into a podcast that welcomes you into a community, a resource center, and a safe place that powers your journey towards personal wellness.
Our goal is you leave us today feeling hopeful, inspired, and ready to live your best bariatric life. Hello, BariNation podcast listeners. It's Natalie. I am willing to bet that you're listening to the podcast episode right now, and you're thinking, man, how can I dive in deeper? How can I get more information? How can I connect more with April, Jason, and Natalie and the rest of the bariatric community? Well, that's where BariNation comes in. BariNation has two parts. It has the BariNation podcast and it has the BariNation support community. We love to bring up topics and talk through topics with experts in the bariatric world on the podcast, but we can't always dive deeper. The BariNation support community is where we can dive deeper. Every single day, there is a class, support group, or meetup led in the BariNation support community. If this is something that you're interested in, head to barination.mn.co today.
Well, welcome, BariNation, to a very special podcast episode. We have the honor today of interviewing Dr. Renee Hilton, an esteemed member of the ASMBS and a phenomenal bariatric surgeon who's going to talk today about advocacy, what it means and what it looks like. Dr. Hilton, thank you for finding the time to join us.
Absolutely, April. Thank you so much for having me.
Yes, I actually had the pleasure of briefly meeting you at last year's ASMBS annual meeting, and you are absolutely a champion for patient and practitioner needs when it comes to understanding what advocacy looks and feels like.
Well, thank you for that. It's definitely a passion of mine, and I don't think I ever intended it to, but it certainly has taken a central kind of, first place role in my career. So it's again, never expected it, but man, I'm really glad that it happened to find that role. And I'm sure we'll talk about that today of how I got into it.
Oh, definitely. Definitely. Before we dive into the conversation, will you take a few minutes and introduce yourself to our friends that have never met you before?
Absolutely. So my name is Renee Hilton. I live in Augusta, Georgia, and I am the current section chief of the minimally invasive and bariatric section. And I'm also the surgical quality officer here, but my roles as pertains to this podcast and within ASMBS, are probably more important in terms of advocacy. I am the current access to care chair. In my second year's chair. And prior to that, I served 2 years as co-chair. And prior to that, I was the president of Georgia ASMBS and the star for the state of Georgia. So that is kind of where my passion for advocacy started, was locally, and it has led me to these positions nationally in ASMBS.
What drew you to bariatric medicine and obesity care?
Yeah, so I've been asked that question a lot, and probably the first person who asked me that question and really made me sit down and think about it was my dad. When I told him I was going to be a bariatric surgeon, he was like, why? Why did you decide to do that? He's like, I thought you wanted to cure cancer or operate on hearts. And I remember my answer because it still holds true today. And I said, no, Dad, I want to prevent people from needing cancer operations and operations on their heart. And that still is probably what I think is the most impactful opportunity that we have as bariatric surgeons. Is this isn't just addressing the disease of obesity, which it is absolutely the gold standard for obesity treatment, but it also prevents patients from developing cancer. It prevents patients from, the comorbidities such as obstructive sleep apnea, liver disease, hypertension, diabetes. Those diseases are awful. And over time, they develop into much bigger processes for patients. And I love the preventative aspect of this operation. It doesn't just cure and treat things, but I feel like we really extend the length and improve the quality of our patients' lives.
I think so many times people struggle to make the decision to undergo bariatric surgery because they think it's only addressing their excess weight, right? Yep. I look a certain way. I know I'm overweight. I'm super morbidly obese. My BMI is through the roof. And you get so down on yourself because you really have tried everything to get to a weight, right, that is happy and allows you to be metabolically well. But I remember in one of the conversations we had with Dr. Chen, he talks about how weight loss is almost like this happy side effect of bariatric surgery. What it's really doing is addressing all of these underlying issues and conditions that we as patients don't necessarily see or even feel yet.
Absolutely. And I just had this conversation with a patient this week who was like, oh, I just feel guilty for, putting my family and myself through a big operation just to lose weight. And I was like, hold on. I said, if I was offering you this operation to cure your diabetes, to cure your hypertension, to get you off your CPAP machine, because you have all of those diseases in addition to your obesity, would you have an operation to get off insulin? Would you have an operation to get off lisinopril and, to stop your CPAP? They're like, oh, absolutely. And I said, well, then tell them that's what this is for. I said, stop telling people you're having an operation to treat your obesity. Tell them it's to treat all these other things. And I said, as sad as it is, the stigma associated with obesity care is still present. It is why the utilization rate for this life-changing operation and even medication is as low as it is that people truly feel guilty about, going and seeking care. They feel that they have failed and that they should fail all of these other things before they, pursue surgery. And I literally think if I put up a billboard that said, hey, I've got an operation that cures all of these things, and I just listed out all the comorbidities associated with obesity and then never put obesity anywhere on the sign, but then do like what you said and say, oh, by the way, there's a wonderful side effect. You're going to lose a lot of weight. Like I'd probably have all of us would have a line, around the block outside of our clinics. And again, I hate to market it that way because again, I do believe that even without any other comorbidity, obesity is enough. And to me, that's really why access is so important. Is to me, access to care for the treatment of obesity doesn't mean access to some things. It doesn't mean, oh, you can have access to, a dietitian, or you can have access to a surgeon, or you can have access to meds. It means that you get access to every evidence-based way that we have to treat this disease. You should have access to it as a patient. And we're not there yet. With insurance companies and again, some patients will have access to some of these things, but it's very rare to see a patient who can truly walk into my door and have access to every way to treat themselves. And, I compare us to cancer all the time. If you look at a patient who has cancer that gets neoadjuvant and adjuvant therapy, they're getting chemo and radiation up front, followed by surgery, and then sometimes followed by additional chemo and radiation or medicine. Obesity is a chronic disease that we really should be viewing with that same mindset. Is, you need medication and, lifestyle, behavioral management, pre-op, you need it post-op, you need surgery. It shouldn't be a pick one of these things and be done. Or, the worst exclusions I see sometimes are when policies say you can have one thing forever. You get a one and done, one surgery. That's it. Yeah. And it's just so fair. So when we talk about access to care, I'm constantly telling our residents, access to care doesn't mean just access to surgery. What kind of access do you have? And that's where access, you can really, really get into the weeds on this because it means something different for everybody. But I do think that moving forward, we have so many great treatment options for obesity that we really have to look at the whole patient and really tailor our approaches to the individual patient, make sure that they have access to everything offered.
I never thought about it from that perspective. But it is so true, right? When you undergo obesity surgery, many times it's not just access to surgery, it's access to a care team, to a dietitian, to mental health support, right? Sometimes it's community. There are way more modalities of treatment that you get as a patient than just that singular procedure.
Absolutely. And I think that's why metabolic surgery is so effective, is because, man, it's a team sport. Like more so than anything else I do in surgery, it is. Yeah. I wish that everything else that I did in medicine had the support of the team the way that I do in bariatrics, because I truly think it makes me a better surgeon to have such a robust team, surrounding me to help take care of these patients.
Yes. When you are a person who is struggling with obesity and you feel like you don't have any options except surgery, shifting that conversation to not focus on excess weight, but instead to focus on either the comorbidities that you are experiencing or what could be waiting for you, right? If you continue to live with this disease untreated, maybe would help shift people's perspective on that.
Absolutely. And, I think probably the most important thing for us to focus on as providers and patients and the ASMBS and other obesity societies moving forward is education and utilization. Before I start talking about the really like nitty gritty numbers of access, I want to tell you a little bit of why I decided to do this. Because not everyone just, rolls out of fellowship or into practice and says, man, I really want to talk to politicians every day and talk about insurance policies. Like no surgeon says that, right? And sometimes our greatest opportunities come out of adversity or, when you get somewhere and things are not good, you see an opportunity to make it better. And, I did my fellowship at Yale University, and Connecticut is a state where, man, it's so progressive and they had great obesity care. And I left Connecticut and came to Georgia. And this was in 2017. And when I got here, I left probably one of the states with some of the best coverage for obesity treatment in the entire nation and came to one of the worst. When I got here, we were one of only 6 states in the entire country who did not have access to bariatric surgery, not meds, not behavioral therapy, surgery. We were one of 6 states in the entire country that didn't have access for our state employees. So the largest employer in the state of Georgia, so all of our school teachers, our police officers, our men and women on our fire departments, everyone who worked for the state. And there's so many more than that. I mean, you're talking about literally hundreds of thousands of Georgians had no access to surgery, even if they had awful comorbidities and a BMI of 60 plus. And I couldn't believe it. I was like, holy smokes. Like, I didn't even know states existed like this anymore. And now I'm practicing in one, and I practice on the Georgia-South Carolina border. South Carolina remains today one of 3 states that still does not have access for state employees. So when I got to Georgia, I'd done a little bit of advocacy work, but certainly was not an expert, really had no idea what I was doing. But I walked into this practice where I was like, all these people that I'm seeing that are so sick, that are taking care of our state don't have access. So what can I do about it? And that's really where my access to care journey started. It's just out of this necessity to be able to help these patients that I was seeing every single day. The first trip I did to Atlanta was an absolute unmitigated disaster. So I think it's probably the first time I've ever shared this story, on air. So maybe people won't think I'm a complete imposter after this, but, I drove over to Atlanta with like no plan in place. Like, I'm going to go to the Capitol. I had set up to meet with like one of the, state, lobbyists and someone within our institution that was supposed to introduce me to people. But I mean, I really had no plan. I didn't know who the players were. I didn't know who was on what side of the aisle and what initiatives were, going to be in session. And I really got lucky because I met who's become a great friend of mine now. She's a former lobbyist and she helps manage our chapter in Georgia. But, I met this woman, and I won't say Kathy's last name, but Kathy is her first name, and Kathy's amazing. So it completely fell through the other meetings that I'd set up. So I'm in Atlanta. I've taken a day off from work, and I call Kathy and I'm like, hey, I'm here and, I don't really know what to do with myself. And Kathy, being a lobbyist for 20 plus years, was like, you know what? Let me go introduce you to some people. And Kathy literally gave me a tour of the Georgia Capitol, introduced me to all of the right people, took me around to representatives and senators who were sponsoring bills that were very important for obesity, and really turns what could have been just an absolute waste of my time disaster day into one that was incredibly productive. But it taught me a very big lesson, which is that advocacy is something that you need mentorship in. It's great to have passion. And I tell everyone that's getting ready to start doing advocacy work, like, the most important part of this entire recipe is passion. If you don't want to do it, if you're not hungry to make change happen and don't want to do grassroots movement, go pound on some doors and hit the pavement, you really don't belong here. But the second most important part of this is having a plan and really being part of a team. Just like you would never walk into the OR and do bariatric surgery without having been trained to do so. Mm-hmm. I think that advocating probably falls in that, kind of in the same category. You need a mentor, you need a teacher. And I'm hoping that through the ASMBS, through my role now in access to care, that is a resource that we want to provide, not just to providers, but to patients. And, the title of this podcast is Advocacy 101. That is the big initiative and the big push. for Dr. Rogers, but one of her initiatives, through her presidency is to really teach our surgeons how to go out and end the stigma of obesity. And it's certainly, me and Chris Gallagher, we've worked together on this project, and Kara Horn, who's an integrated health member of our committee. We're very passionate about moving this initiative forward, which is to create almost a school, or a course that people can take in advocacy. That way they are getting the training that they need, and they have a plan, because most people have already dabbled in politics a little bit, but they're like, man, how do I make happen what just happened in Louisiana last year? What just happened in Georgia a few years ago? So I'll kind of fast forward go back to my advocacy story. That was in 2017. That was the first disaster day on the Hill, where I knew nothing, and am just fortunate to found a friend in Kathy that could really show me the ropes. And our advocacy journey in Georgia was 7 years. It took about 7 years from the time we lost the benefit until we finally got it added back into the benefit plan in 2021. And so advocacy, it was not fast, but over that time period, I learned a lot. I was able to partner with our state chapter in Georgia, which I think is a huge resource for physicians, practitioners, patients, or kind of your local organizations, your state chapters through ASMBS or the American College of Surgeons in your state, through the OAC. A lot of them have regional kind of local resources to take advantage of. And so we started this journey in Georgia, where we went to the Capitol multiple times, and we really started organizing our advocacy efforts around our ASMBS state chapter days. So every year we kind of gave an update to the membership. And we said, okay, this year we're going to plan a day where we all go to the Capitol. Everyone who wants to go, this is going to be the day. Here's the sign up link. And we're all going to go. And we had a set agenda. It was planned. So if you'd never been to the Hill, this was a great way to do it, through your state chapter or through an organization, because you showed up, and here's your folder. April, here's your agenda for today. At 9 o'clock, you're set to go in and talk to Senator Warnock or, Oscoff. It was, I'm using Georgia politicians because I'm in Georgia. You had an agenda and somewhere to be. And you also got the rundown that morning of, hey, here are our key talking points. Today we're going to talk about TROA, or we're going to talk about state employee access to bariatric surgery. It really is a user-friendly way to get your foot in the door, rather than just going by yourself and trying to brave this. I think that organization through the state chapters is a great way to do it. So we did a lot of those events, and then we really took advantage of some of the resources provided by some of the top obesity organizations in the country, such as, the Obesity Society, ASMBS, the OAC. All of these organizations have patient and provider access to toolkits where you can go online and print off white sheets and things, so that a lot of people don't even know what a white sheet is. So a white sheet is a one page where, after you go and talk to that politician and tell them how amazing bariatric surgery is, you leave them with the sheet. And the sheet has really important information on it, like demographics about the state. This is the percentage of Georgians who have obesity. It's actually very high. These are the percentage of Georgians who are overweight. This is what it costs to treat diabetes in the state of Georgia. These are all the other states in the country that have access to this benefit. But it's just a one page that has all of these key points that you probably talked about. And now you're going to leave it with them. So when they go meet later, with their staffers, or hopefully at the governor's office, or, on the floor of the House or the Senate, they can take this sheet with them, and it refreshes everything that was really important.
Yes.
And people don't have to do that. These organizations have already done it for you. You can literally go print them off and just take them. That's kind of how we started and where it ended up. And it was a long journey, but ultimately over 500,000 Georgians now have access to metabolic surgery that they didn't have when we started. So I'll never be able to operate on 500,000 people, not even with the most robust surgical career. That's one of the things I love about access is, through policy changes, you have an ability to impact millions of people.
And your story really beautifully highlights kind of the three things that you talked about when it comes to advocacy. You have to have a passion there to learn and understand and to speak for people that maybe don't have the ability to speak for themselves. That mentorship component, right? we brought our colleagues with us. We gave them this action plan. So even if that passion isn't necessarily there, there's a pathway for you to be introduced to what advocacy looks and feels like. And then that time component. I think oftentimes we are hardwired for immediate results. And we think that as soon as I ask somebody or I tell somebody about this life-changing opportunity, they're going to immediately act on it, right? Or as soon as I talk with Senator Warnock about it, he's going to say, yes, absolutely, right, we're going to move forward with that. But advocacy takes so much time. Change is something that really moves at a snail's pace. And you have to be in it for the long haul if you really want to see that change take place.
Yeah, and it's so funny because the week before Georgia state health employees that went back into the benefit plan, I actually was on an ASMBS leadership call with Joe Northrup and Mickey Seeger. I think Chris was on the phone, a few other people. And I literally said the words, God, advocacy is just soul crushing. I said, I am just crushed. Like, I've had all these meetings and I thought by this point I would have gotten somewhere and it's not working. And it just is soul crushing. You do all this work and it doesn't happen. And literally a week later, I texted them and I was like, I'm no longer crushed. I'm reinvigorated. It worked. So there are highs and lows, right? You need those highs because, man, when you get a win like that and you immediately see the results because you have patients that have been in contact with you and advocating for themselves for the 7 years that we've also been working on it as physicians. I mean, overnight, we had a list of people that we had kept. We kept this list of state employees that would just call us routinely and be like, hey, do I have the benefit yet? Wow. We went through that list of hundreds of patients and said, just so you know, open enrollment's coming up, sign up, make sure you're in this tier so you get coverage. And, the doors of our offices just blew off the hinges with new patients come January when they, realized that they had access to this. And so I think that's another piece that I want to make sure that I really, really talk about today is the patient advocate is the most important person in the room. I've been to the White House with ASMBS and sat and watched the conversations, even with the Biden administration. We met last year with their domestic policy council, and we took 3 patients into that room. And when the patients start to talk, and I saw the same thing locally in Georgia, the politicians listen. Like these are the people voting for them, right? Like these are patients who also, they have this ability to tell their story where it's not just money. It's not just a surgery. It's not numbers on a spreadsheet and percentages. It's a real person saying, I had to quit my job because the edema in my lower extremities is so severe that I can't work. Mm-hmm. I now have Medicare because I can't work, so I'm disabled. Medicare supports treatment for lipedema, but it doesn't support care for my obesity. It doesn't support the medications that I need. Because this was a patient who had had surgery and still required that adjuvant therapy. And I think it was incredibly powerful to hear her story and that you say I'm disabled because I have this condition and you gave me Medicare, but Medicare won't pay for the drugs that I need to treat the condition that you said I'm disabled for. I mean, it's just this whole convoluted cycle that I feel like when politicians or staffers or whoever you're meeting with are able to see a real person, and it's also very, very powerful when you take a successful patient. When you have that patient that says, I started this journey and weighed 550 pounds. I was disabled. I had diabetes, hypertension, OSA. Now I weigh 250 pounds. I've gone back into the workforce. I'm doing all these amazing things. It doesn't always have to be a sad story. It can also be a really positive story. And I feel like those positive experiences and the negative ones, they're both equally empowering for different reasons.
Yes. The patient voice from our perspective, and now granted, this perspective only goes back 5.5 years, but the only reason I decided to have bariatric surgery was because a friend of mine underwent the procedure and was brave enough to talk to me about why she did it and the process that she went through. But up until that moment, bariatric surgery was not something I ever considered for various different reasons. But when patients have the ability and a platform to share their story and to talk about the impacts that the disease of obesity has had on their life prior to, and then the impact surgery has made right afterwards, the most amazing thing happens. People all of a sudden can hear the story. and they see it and it becomes very real. So instead of something that maybe they've seen on TV or their second cousin's aunt's neighbor's brother had, now it becomes something tangible that they can experience, they can understand, they can find connection with. So, the advocacy piece absolutely goes two ways. You can have the professionals doing this very important work that you are doing. But as a patient, I also have to be open to hearing the stories, to understand what's going on, and to shift my mindset when it comes to what this disease is actually all about. Because if those things aren't happening, then it's almost for naught. It's wonderful that it's now available to somebody, but if they're not going to access it, you need both.
Yeah. And that's what, when I talk about access to care, I have a slide that I show a lot, and I talk about the difference between access and utilization. Because if you're new to access to care, sometimes people don't understand these words, right? So the example that I use that most everyone understands is my Peloton bike. I have access to it. It's upstairs in the workout room. I don't utilize it, but once a month or once every 2 months. So you can have access to something and not utilize it. If you have access to bariatric surgery, but there's so much stigma surrounding this and you're afraid to go in, even for the initial consultation, that to me is one of the biggest problems that we have right now in 2025 is we have this amazing, life-changing, saving operation that we know works, and 1 to 1.5% of people with coverage actually use it. If you actually look at insurance coverage across this country, over 90% of Americans have access to metabolic surgery, which is just staggering. Like we only have about, less than 10% of the country without access to surgery. So why do only 1 to 1.5% use it? And I truly believe the biggest reason is the stigma attached to it. And I'm incredibly vocal and open about my own struggles with obesity. And, after having 2 babies, I could not lose my weight. I went on tirzepatide, and I have publicly at podiums told people about my weight loss journey. And I think that once we get even physicians to stop shaming themselves, because I have a lot of shame, even as a person who's boarded in this specialty, it's still like you're a little embarrassed to tell people I'm on a medication for weight loss. Like no one ever wants to talk about that. But until we all do, and we openly address the stigma associated with this disease, we're really not going to move that needle on utilization, which I truly think is probably the most important needle to move right now.
Agreed. It's why one of the reasons that we created BariNation is we were seeing this lack in people utilizing the care. I underwent surgery and had a wonderful surgical team, but my aftercare was not what I needed. And then life changes, as it does for so many people. I moved, my insurance changed, right? I changed jobs, finding a new doctor. And I had a difficult time advocating for myself and my own needs. And we created BariNation because we wanted a place for patients to be able to go, a clearinghouse of sorts, where they could tap into advocacy. Even if they didn't understand exactly what it was or why they were doing it, they could find a safe place that they could find the information that they need to make the informed decision to undergo bariatric surgery. And then that mentorship component kicks in. We're going to guide you every step of the way. We have those white papers, right? We have these patient support guides. We have support groups and classes and meetups that literally guide people through every stage of the journey. So no matter when and where you find us, if that advocacy, if that connection, if that support, if that education is something that you would benefit from, you have an inclusive place to go. So no matter how old you are, no matter what kind of bariatric surgery you had, men or woman, does not matter, right? This space, this community is built for you, because that patient advocacy piece we saw was missing. Just like that, only 1% of people are accessing this life-saving surgery. Why? Why is it this way? It's frustrating.
It is. It's incredibly frustrating. And I feel like, too, the most frustrating part for me is you have some people that they want it so badly and they don't have access to it. And then we have this huge percentage of patients that have access to it, but they're too scared to actually go utilize the benefit. And for me personally, I think that education, again, it has to be about education. So other things that I would encourage providers and patients to do within their own communities is, every once in a while, where can I start? Like, maybe you're not ready to take that big leap I talked about. Like, maybe you're not ready to go to the state capitol or come to DC. Start locally, start in your own healthcare system. Go give grand rounds. If you're a provider, go give grand rounds to other groups that may not understand the disease of obesity or who bariatric surgery is for. I routinely get told, oh, well, I was going to send a patient to you, but they're not big enough. And I'm like, well, how big were they? Oh, they were 250 pounds, 5'2" female with diabetes. And I'm like, big enough. Like, it's not about big. It's not about size. It's about the comorbidities. And everyone, I think, thinks that the bariatric patient is the patients that you see on a lot of the popularized TV shows, right? Like, and, I actually have a slide in a deck that I use a lot that says, this is not my 600-pound life. For most of us, it's our 200 or 300-pound life. It's not 600 pounds. It's 200 pounds in, comorbidities. For myself, I had obstructive sleep apnea. And that was kind of the trigger that made me as a professional say, okay, I'm either these GLP-1s are either going to work or I'm about to have one of my partners sleep me. So I'm going to do one or the other because, I'm a mom and I've got 2 young toddlers and I know where this disease goes. Like, it's not magically going to get better. I have tried for years to lose weight and everyone was like, oh, but you're not that big. Like, what are you talking about? I'm like, yeah, but I'm unhealthy. Like, I have a healthcare problem. Like, I literally have severe sleep apnea. So I have to do something to treat this. And I'm hoping that as more providers that suffer from the disease of obesity, more people in healthcare come forward and talk about it, maybe we can start to put an end to some of that stigma and the shame associated with it. But, there's no bad place to start. If you want to get engaged with advocacy, do something local. We're doing some pretty cool stuff in Augusta right now where we're actually going to work with some of the community centers to do things like cooking demos for families. So we'll have like an information session where anyone in the community can come, parents, kids, like they all come to this place. We call it the Hub. And we just give like an information session, a short one on like, hey, this is what the disease of obesity is. These are your treatment options. If you're interested in any of these, there's some handouts, take them, no pressure. Then we have like some of our RDs that will do like a cooking demo or, we even give out, free, like, fruit, vegetables, like they can actually get a prescription through some of their insurance companies to get fresh fruit and vegetables. So, you can advocate in a local way that is incredibly powerful within your community. And then through partnership with organizations like the ASMBS, I really think you can then move to that next level of your journey if you want to advocate on a bigger level. We have some amazing opportunities this year for members of the ASMBS. We will be having, Hill events in DC. We're having our annual meeting is in Washington, DC this year. So what better place to do some advocacy work before the meeting starts, right? So I'm very excited about this event. I think that we have an opportunity to really increase utilization through direct to consumer marketing right now. You see a lot of kind of popular, medical, whether it be medicine or surgical industry partners, they're starting to direct market to consumers. And what I've wanted to see for years, and I really hope that the ASMBS makes it happen under Dr. Rogers and Diane's leadership, I want a commercial. I want a big primetime commercial that airs for a solid minute during halftime of the Super Bowl when everyone's watching the commercials. This is my pipe dream, April. We probably will not get a Super Bowl commercial at first, but if I could do anything, that's what I would have. And I want it to be as catchy as the Ozempic little jingle that you hear, where people are singing the Ozempic song. Like, I want a commercial that really promotes bariatric surgery and the treatment of obesity. And I want it prime time for all Americans to see, because until we start making this like mainstream, when have you ever seen a commercial on bariatric surgery? You don't, right? But yet you turn on your TV and how many commercials have you seen about weight loss drugs or cholesterol medications? We struggle to really keep up with big pharma. They have a lot more money than us. But I really do think that some of this direct marketing to the consumer, and the consumer in this case is the patient. When you tell patients, we have this, it's available to you, come use it. That's when I think the patient will be the most powerful advocate for themselves, because they're either going to utilize the benefit or they're going to realize they don't have it and get involved in this advocacy fight, and which is really what we need.
Yeah. I think when patients really start making the mindset shift and they go from this is my fault to this is a disease that is out of my control and I need medical intervention, right? Then that shift happens. And I agree. That's my dream as well. Dr. Hilton, I would love to see a bariatric surgery commercial in the middle of the Super Bowl, because I know how impactful it's been on my life and the life of millions of people. In BariNation, we have thousands of members who can speak to the impact of it. And the more work, time, and energy we can put into shifting that conversation, the better. Even this weekend, we were entertaining friends, and my husband struggles with his weight, and many people in our friend group struggle with their weight. And even though they've seen me undergo bariatric surgery, right, the one of the founders of BariNation, they still believe that their weight is 100% based on bad decisions they're making. And these are people, my husband, right, very close friends. That desire to hang on to the shame and guilt is so strong that it almost feels impossible to shift, but it can be done. And the advocacy work, I think, when it comes to patients, is you have to be open to understanding what you're dealing with from a different perspective. You have to be brave enough to step back and go, maybe this isn't 100% my fault.
Yes. That is absolutely probably one of the first things that has to happen. Is it's really hard to advocate for yourself when you have that shame and guilt. And I don't feel like sometimes patients with other diseases, they don't have that. If all of a sudden they woke up and said, you know what, we're going to take away all of your medications for this disease, there would be riots. People would be on the hill saying, how can you do this to me? I have a medical condition. Obesity has been defined as a medical condition, I mean, for literally hundreds of years. I was actually astounded to see, like, in some of the oldest medical books, you can see people already talking about the disease of obesity hundreds of years ago. And it's been recognized by major medical societies for upwards of 20 and 30 years. So if patients are listening to this, I want you to hear one thing from this podcast. If you hear nothing else, obesity is a disease. It's not your fault. It's multifactorial, and you deserve treatment. You deserve to have care. You deserve to have a provider and a team taking care of you that's going to advocate for you and get you access to all of the things that you need. And again, that's one of the things I love the most about my role in ASMBS with access to care is I hear from people across the nation from all 50 states, and every state and every hospital, every region, they're all having their own like little unique struggles, right? Like what's happening in California is not the same as Georgia, but this position has just been mind blowing and opening for me to see how many obstacles still stand in people's way to get the care they need. Because sometimes we just say, okay, well, 90% of people have access to surgery. But if you have access to surgery, but your insurance is saying you have to jump through all these hoops, like you have to go through 12 months, every month you have to be weighed. You have to do, you've got to do this psych visit, but we're not actually going to pay for it. So you got to pay out of pocket for your psych visit. And we're going to let you have surgery, but your deductible for bariatric surgery is 3 times higher than the deductible you would have to pay if you were having cancer surgery. We see all of these things. So just having access to obesity treatment does not mean you have great access. And that is where I think, our next big fight for this comes, is we have more treatment options than ever before. And one of the biggest pushes right now is how do we advocate for all of these things so that we're not limiting one, while getting access to the other. And, you've probably heard before, like a rising tide lifts all boats, right? Like we shouldn't just be advocating for medicine or just be advocating for surgery or just be advocating for behavioral therapy. It should be everything altogether. Our patients deserve all of these modalities in combination. So I'm very passionate about leading people in this effort. I hope if anyone's listening to this and they're like, man, I really, I don't know where to get started, but I'm in the ASMBS or I'm in one of these organizations, reach out. We have committees, we have task forces, places that we can put you, so you get that mentorship that you need. And if you're a patient hearing this, and you've had surgery, you're like, man, like I'd really like to share my story. We have organizations that are begging for patient advocates, that are, again, your story is so powerful. So we really want to encourage people to speak up.
Yes. Well, and it's one of our roles that we play in BariNation. We have members in our community who are thinking about having bariatric surgery. So they haven't committed to it yet. They might not have even found a surgeon, but they know that this is something that they think they want to do. And when they join our community and they start attending our live events that are built just for people who are in that preoperative stage. It's them starting the advocacy work. It's them onboarding the tools and the words, the phrases, right? And that learning that's needed to persist through treatment. Because it's one thing to make the decision to have a bariatric procedure. It's another thing to really get yourself to the start line, as we say, just for all those reasons that you mentioned. You could be looking at 12 months of work that you, the patient, has to sustain through to get yourself to surgery. So that's the role, one of the roles that we see ourselves playing in this advocacy work, is that you need that mentor. You need that person who's there by your side, guiding you through this, helping you through it all, because doing it alone is intimidating. And I the last time I saw a stat on the number of people who drop out of the surgical process because they don't have that mentorship or that advocacy is huge.
Agreed. And I think sometimes, even if you are not sure if you have coverage, if you're a patient who's hearing this, and you're like, man, I have no idea if my insurance covers surgery, go reach out to a local bariatric office. See if you can become a patient. A lot of times, like I know we do it for our patients. We will literally verify your insurance for you to make sure that you have the benefit.
Yeah.
And sometimes just don't say no. Like, just be that patient. If you don't have coverage, you know what? Go ahead and try to enroll in the program so that when you get that denial, you can now reach out to your insurance company and ask them, why don't you want to care for this medical problem that I have? Mm-hmm. I tell patients all the time, you know, I don't hear no the first time, the second time, the third time, even the 10th time that an insurance company says it to me. And I've even been able to make some friends, in some of these insurance companies with medical directors and people that are reviewing the policy. Because sometimes, again, we talk about educating the patient, but sometimes it's educating the insurance companies. They
Mm-hmm.
don't know, like they're just trying to update their policies and keep up as well. But I've had several recent successes as Access to Care Chair where we've had meetings as an organization with these insurance companies. And when we show them the new guidelines and we tell them, like, here's your 2022 guidelines of what should be covered, all of a sudden you start to see changes in the policy. Mm-hmm. And that's when it becomes really exciting. The other thing I will tell patients listening is if you tried 5 years ago to get access to surgery and you were denied, try again. These policies change. Some of them change every quarter. Blue Shield in California gives me whiplash. I swear that policy changes like every day. I feel like I need to go check the blue policies in California because they change frequently, but they just made huge changes. You know, if you're listening in California, they just made huge changes to their policies where they got rid of their 12-month requirement. So one of the powerful things about being in the ASMBS and being on these committees is we have people watching these policies. The second that we recognized that a policy made a huge change like that, I got on the phone and, called up Pearl Ma in California, and she was like, I know, I saw it. Like, we're on it. So now Pearl can go, disseminate through the rest of California. Hey guys, like, this is a big change. They called patients that had been waiting for months for no reason, just an arbitrary number set by an insurance company of 12 months pre-op, immediately got to come to surgery because they were ready. Mm-hmm. And that's the other part of this advocacy journey that I don't think will ever be over for me, nor should it be for any surgeon or provider or patient, is yes, you have access to care, but we can always make it better. Like, you may have access to surgery, but if you have an insurance company telling you you need to lose weight in a program pre-op, you need to be in the program for 6 months, and you need to try all of these things before we let you have surgery, that's not fair. Those are hoops to jump through. It's not based off evidence. And to me, that is still a barrier and something that needs to be broken down. So just because 90+% of the country has access to surgery, it's not all great access. And I'm truly not going to be happy as a champion for access and advocacy until a patient can walk in, have a conversation with their provider, and walk out of that office with a plan that has been determined by that patient and that provider's interaction based off what they medically need, not what a third-party insurance company says they need.
Yes. Wouldn't that be an amazing future?
It would.
Of obesity care.
Absolutely.
Dr. Hilton, we've been asking our guests kind of what their bold predictions for obesity care in 2025 will be. And it sounds like yours would probably be rooted in advocacy, but I'd love to know what you think. Do you see something big changing in this realm for patients this year?
Yes, I think there's been a couple of recent changes that I'm watching very closely. One was, Recently the Biden administration announced that Medicare, Medicaid would start covering GLP-1s. This was a massive news drop at the end of the Biden administration. If that went into effect, it takes a while for Medicare ruling to kind of, trickle down and happen. It would be about 2 years. But for CMS, when they make big changes like this, they only have 60 days before they have to do it. So if this rule stands and CMS is now forced to cover GLP-1s, then you could be looking at patients with Medicaid potentially having access to GLP-1s as early as March of 2025. So again, don't hold me to that date. This is all like my pipe dream. But in a perfect world, and what I think would be like the most, like the biggest change that would happen in 2025, is probably going to be around some of these, the GLP-1 medications. And, I advocate a lot for medications along with surgery. And the reason that I do that is I truly believe that these medications are a gateway for many patients. We have tried for the past 50 years to move that needle on the 1 and 1.5% for surgery, and we have failed. Yet all of a sudden you look at who's on a GLP-1. It's everyone. I mean, you walk through the grocery store. I mean, it's your mother, your brother, your cousin. I mean, everyone, people who have never wanted to talk to me about metabolic surgery or what I do, even in my own family, are calling me like, hey, tell me about this drug that I saw on TV. So I love the fact that I think these medications are going to bring people into our offices. And they're going to get them excited to start talking about obesity treatment. Medications are not for everyone. These medications are wonderful. But if your BMI is above 40 and you have comorbidities, really surgery is probably the best long-term solution for your obesity. It can be combined with medication. But if the only way that I can get a patient in my door to talk about bariatric surgery is to first have a conversation about trying obesity medicine, I think that is completely reasonable. And I'm excited to see what better access, even to some of the medications, could mean for access to surgery. I also think that with the expense of the GLP-1s, these drugs are incredibly expensive. We don't know how long patients are going to need to stay on GLP-1s. A lot of the early data is saying forever. So when you start looking at the cost effectiveness of bariatric surgery, it's incredibly cost effective. And I do think also patients should hear upfront all of their options for treatment. Because if given the choice between an injection every single week for the rest of my life or a 1-hour operation that gives me, potentially even more benefit, I just think patients should be allowed to make that decision and should be educated on all of their choices. And so for me, I do think that as more and more medications come out, I actually think access to surgery is going to improve because insurance companies are going to see that we're the gold standard. We are better than the medications. As much as I love these drugs, and you're talking to someone who is on one of these drugs, I love them. I think they're great. There is no substitution for bariatric surgery in terms of treating morbid obesity. It is the best. It has the longest effect. It's safe. So it's not going anywhere. Bariatric surgery is always going to be, in my opinion, probably one of the best options for patients with obesity. But again, I keep preaching utilization has to be a part of the access and advocacy conversation. If putting patients on medication and getting them excited about some of their weight loss and starting their journey with medication will then lead them to a conversation about surgery, I'm happy to be part of that conversation.
I think the exact same thing that you just said. And it's kind of related to your bold prediction. If any of my primary care physicians in my entire life before surgery had said, I want to refer you, or your next appointment is going to be with an obesity medicine specialist, with a metabolic specialist, I would have been introduced to that. But at no time did that happen. I think the shift is happening. And I think with primary care physicians saying, there are these, anti-obesity medications, we can explore that. And then I'm going to connect you with, a specialist in this area. It absolutely is going to open the door. And if you start on medication and then you progress to surgery, phenomenal. If you start on medication and it works, or if you start on medication and it doesn't work, side effects, whatever reason, you progress on to surgery. It's starting the conversation. It's shifting that shame and stigma that surrounds obesity as a you problem to obesity as a disease, not a decision that you're making. Let's move you on to the care and treatment that you need and deserve.
And the conversation, I'm already seeing this conversation evolve even at a national level. So in meetings that I had last year in DC at obesity summits and diabetes summits, and even in the White House, 10 years ago when I started doing this, and even 5 years ago, I was still telling people what bariatric surgery was. Like, I would meet with governors or representatives and senators and be like, wait, what do you do? What is bariatric surgery? Tell me about that. And now I'm walking into rooms and these politicians are incredibly educated on what a GLP-1 is, what surgery is. So there's been an evolution. For me, it's no longer obesity is a disease and we have this medicine, this surgery that works. Now it's, we have these options. How do we pay for it? Those are all of the conversations I'm having around access to care and advocacy right now. Is everything is expensive. How can we make these insurance companies and other people that are paying for these benefits, how can we make them see that the investment is worth it in the end? Because, and we shouldn't have to, right? Like, no one treating cancer has to ever argue that it's profitable or you get a return on investment to treat cancer. But we are still having to do that. As physicians who have obesity and patients who have the disease, we are still having to argue that we are a good ROI, return on investment. And I long for the day when that no longer is a conversation. But the reality of my job right now is that still is a conversation. And the good news is we are incredibly cost effective. It's absolutely a conversation that, I differ with one of my mentors, Joe Northrup, a little bit on this. Joe says you should never talk about money right off the bat. When you're advocating, it should be all about the disease and all about the patient. And I disagree a little bit because I do think politicians and insurance companies and the people that are paying for everything, it's a real problem, right? I mean, if you want to go buy a car and you only have a certain amount of money in your checkbook, you can't go write a check for the car or use your, we can only pay for what we have in the bank. And the reality is, if right now we forced Medicare to go out and cover GLP-1s and pay for all this medication for everyone who needs it, it would bankrupt Medicare. That is the reality of how expensive these things are. So I think looking at the disease of obesity, where people stand with BMIs and comorbidities, and then look at what is the best long-term treatment while also being financially responsible with our healthcare dollars. I think that's where advocacy gets a little tricky, right? Because as someone who's an advocate, you want everything for every patient, but we also want to be able to pay for all of our patients to have care. And so there has to be some financial responsibility that is discussed as part of advocating for patients. So I do think you have to have a little bit of conversation and knowledge about financial state of when you're talking about advocating for coverage.
Yeah. From my patient side, when I think of the return on investment that I've gotten, right, my out-of-pocket cost, I think, was somewhere in the neighborhood of $10,000. This was five and a half years ago. If I would have continued to live my life at 327 pounds, my obstructive sleep apnea could have become deadly. Cancer runs on both sides of my family. Fatty liver disease would have had me in and out of the hospital. My quality of life would have drastically decreased. I probably couldn't have remained a classroom teacher. Like, all of these things would have continued to deteriorate in my life that would have taken me out of the workforce and out of my ability to provide for my family and pay taxes, right? Yes. The return on the investment that I made personally is a life that I really could have never imagined or dreamed of, an extremely active, professional life, contributing to society as a whole and helping others, right? Continue to just rinse and repeat that return. If we're doing that as a nation, I can only imagine the financial, economic, positive impacts that it would make as a whole. So I do understand it. Money talks. And if that's how you get people to listen, fine. Because the end result is the same. People are going to get the care that they need and deserve.
And that's where it gets really tricky, right? Is how do you quantify the return on investment? Like, what is it worth to extend your life by 14 years? Which is what some of the long-term studies in bariatric surgery have proven, that, you can see an extension of 14 years of life. Like, what is that worth to you? What is it worth to be able to walk into your child's school and, go to a parent-teacher conference? I had a patient tell me one time, she sent me a picture of it. It was the first time she had walked her child into the first day of school. Every other year, she'd been in a wheelchair. And she said, I was always the sick parent with my kid. And she said, She said, you have no idea how much you've changed my life by giving me the ability to walk my child into school. There's no price tag you can put on that. If you're listening to this and you're not getting a little bit of goosebumps hearing stories like that, like you're probably in the wrong field. Like it's those types of stories should impact you, and it should, really encourage you to get out and do something to make these changes happen. And I think it's really hard to put a price tag on some of the things that we see as providers and people who take care of bariatric patients. It has never been about the weight loss for me. It's wonderful to see that, but it's so much more than weight loss. When I look at, I told you I'd talk about this a little bit because we have something novel here in Augusta. We have a women's health initiative where we truly take it upon ourselves to not just address weight. Like we are looking at the whole patient. And when we have these women that come in that want to have a conversation up front, not just about their weight, but about, their future fertility options. Maybe they haven't been able to start a family, or they want to talk about family planning, or their risk of endometrial cancer, which is dramatically higher in women with obesity. These are all things that no one's ever looked at the cost of this, right? Like, how much cost savings do we get when we take a 25-year-old who has stage 1 endometrial cancer and we give her bariatric surgery, and all of a sudden, instead of her having to, go down a road, which is probably a hysterectomy and other major, just life-changing things for her, we treat her obesity, we treat her endometrial cancer, and all of a sudden she has just a whole new outlook on life where she now is going to be able to be a much more productive member of society. Maybe she's going to go on to build that family that she wanted because we've given her fertility sparing treatment options. Again, it's really hard to quantify these things, but I do think that it is an area that has been immensely understudied, looking at very specific patient populations and the cost of not treating these patients with their obesity. And when you look at women's health care and you start looking at things like obstetric mortality, like when women with obesity go on to get pregnant and have complications during childbirth, or women who have infertility that's largely related to obesity and have to go through very costly fertility treatment options. I think that there's a lot of areas that are just untapped when you start looking at return on investment. And again, I don't think you'll ever be able to put a price on some of these things. Like the reward that you're going to see in the patient's life is just going to be so impactful and so tremendous that I just don't think you'll ever be able to put a price tag on that.
All right, BariNation, what did you think of that conversation? Dr. Hilton and I actually continue talking, but we just ran out of time here on this episode. So if you are a member of BariNation, you can watch and listen to this full, complete, unedited episode. And there's about 15 or 20 minutes left, and it is an amazing part of the conversation. I want to thank Dr. Hilton for joining me. We had clearly an amazing conversation. And not only is she a phenomenal bariatric surgeon, but she is tirelessly working to improve access to patient care. Advocacy goes beyond looking out for everybody's needs. Advocacy really can start in our own personal journey. And I know there was probably something along the way that you wanted to talk to your bariatric surgeon or primary care provider about, but you were nervous. You didn't have the right words. You were maybe feeling a little bit ashamed about what you were experiencing, and you just didn't know where to start. In BariNation, we create these safe places for you to practice having these kinds of conversations with your primary care provider, but you first get to have them with peers and with experts. BariNation is that place that you can say, I'm worried about this, or I'm struggling with this, or I'm a little bit concerned about that. And in the community, you will find the ideas and the voice and the words that you will carry forward in those conversations with your primary care team. If you are looking for the safe place to practice advocacy, I invite you to join us in BariNation. Visit us at barination.mn.co. I can't wait to see you in the nation soon. That wraps up another empowering episode of the BariNation podcast. If you enjoyed today's episode, keep the conversation going by joining the BariNation membership community, where you can attend live support events, access on-demand resources, and find a caring community.
Join us at barination.mn.co. If you found this podcast valuable, help us produce it by becoming a $5 monthly supporter at BariNationPodcast.com.
And just remember, at the end of the day, you've got this, we've got you, and we'll see you next time. Bye, everybody.